Yeah, like.
Good evening. Welcome to our very interesting and a practical webinar today. Walk-in cataract patient, how to diagnose, treat, and when to refer. Of course, you'll not refer cataracts, but of course, that is the title of the webinar which the sponsor has given. Now, anyway, the webinar has a galaxy of speakers, and Dr. Harbans Lal, who is the president of AIOS and director of Delhi Eye Center and co-chairman of Department of Ophthalmology, Sir Gangaram Hospital, will be chairing the session. Moderating along with me and doing the majority of the job would be Dr. Manoj Mathur, who is the Honorary Treasurer AIOS and belongs to Swaroop Eye Center and Medivision, Hyderabad. Along with him would be moderating Dr. Manbir Singh from High Tech Eye Care and Laser Center, Bhopal. Our expert panel will consist of Dr. Samar Basak from Disha Eye Hospital, Kolkata, Dr. Partha Biswas from Trinetralaya and Netralayam, Kolkata, Dr. Namrata Sharma from API Center for Ophthalmic Sciences, AIMS, New Delhi, Dr. Krishna Prasad Kudlu from Prasad Netralaya, Udupi, Dr. M. Vanati, who is from API Center for Ophthalmic Sciences, AIMS, New Delhi, Dr. C.V. Gopal Raju from Vishaka Eye Hospital, Andhra Pradesh, Dr. Elan Kumar Pasupati from Navashakti Netralaya, Bangalore, and Somashila Murthy from Shantilal Sanghi Eye Institute, Mumbai. Our expert panel will also consist of Dr. J.S. Bhala from DDU Hospital, Delhi, Dr. Pradeep Kumar Mohanta from Netra Jyoti Eye Hospital, West Bengal, Dr. Amit Porwal from Choitram Netralaya, Indore, Dr. Vardhaman Kankadia from Asian Eye Hospital, Pune. We have Dr. Kasturi Bhattacharji, who is from Shankaradeva Netralaya, Guwahati, Dr. Anaga Herur from Anil Eye Hospital, Mumbai, and Dr. Deepak Mishra from BHU, Varanasi. Our speakers are eminent, and most of them this time are from Madhya Pradesh, and they are Dr. O.P. Agarwal, who is the opening batsman, and will speak on phaco and hard cataracts in difficult situations. He'll be followed by Dr. Purendra Bhasin, who is founder and medical director of Ratan Jyoti Group of Hospitals, Gwalior, and he'll speak on phaco and small pupil with or without pupil expander devices. Dr. Prerna Upadhyaya from Seva Sadan Eye Hospital, Bhopal, she's the medical director there, will speak on an interesting topic, Toric IOL, and that will be followed by Dr. Pawan Stapak. He's the chairman and director of Jan Jyoti Netralaya, Jabalpur, and he'll speak on flax. And the webinar is supported by Alagan. I hand you over to the moderators, co-moderators of the session for further proceedings. Stop share.
The first speaker of the day, Dr. O.P. Agarwal. To share screen, please.
Sure, sir. Good evening. And at the outset, I thank AIOS for giving me this opportunity to share my talk on phaco in hard cataracts in difficult situations. I am audible?
Yes, sir. You're audible and slightly visible.
Yeah.
Okay, thank you. So I am going to talk hard cataracts. Hard cataract itself is a difficult task for all of our phacosurgeons, but hard cataracts in difficult situations, many situations are sometimes difficult to the next one. Yeah. Yes. So performing phacoemulsification in very hard cataract can be challenging. It is always challenging. But with careful planning and technique, successful outcomes can be achieved. Here are some pointers to consider, like preoperative evaluation. It should be thoroughly assess the patient's preoperative condition, including the density and size of the cataracts, corneal endothelial cell count, presence of comorbidities, and any associated ocular pathology. This evaluation will help you plan our surgical approach and anticipate potential difficulties. The patient position should be proper. This is a very difficult thing. I'm going to talk about one of our patients having kyphosis, and it was very difficult to operate. How we have operated, I'll explain in my video. we have to avoid premature incisions. The capsular axis should be well centered and adequate sized capsular axis for very hard cataracts. The hydrodissection should be adequate. The hydrodissection is the same as we are doing in all other cataract surgeries. The phaco technique. This is very important for very hard cataracts. We have to modify our phaco technique for hard cataracts, use higher ultrasound power settings and more effective vacuum levels to emulsify the dense nucleus. Consider using a combination of techniques such as sculpting, chopping, and stop and chop to facilitate nucleus removal. I always advise that before handling very hard cataracts, we should learn phaco chop, which is very important for hard cataracts to reduce the utilization of phaco power. The nucleus removal is very important. Divide the nucleus into smaller fragments using phaco techniques and remove them piece by piece. Use adequate vacuum levels to securely hold and remove the fragments without excessive stress on the capsular wing. We should divide the nucleus fragments completely. There should not be attached fibers with each and every nuclear fragments. The cortical cleanup is same as we do in all other cataract surgeries. The viscoelastic and IOL implantation is one of the same thing for hard cataracts. But here post-operative care is very important. Emphasize the importance of post-operative care and follow-up visits to monitor for any complications. Prescribe appropriate medications and provide detailed instructions. Why detailed instructions? Pre-operative as well as post-operative instructions with hard cataract patient is important because there are chances of corneal edema post-operatively for a few days. So this is very important. We have to remember that each case is unique and it is essential to adopt your surgical approach based on the specific challenges encountered during the procedures. Consulting with experienced colleagues or mentors can also provide valuable insights and guidance for managing difficult cases. So here I am presenting few of the videos. This is very hard cataract. We need good microscope, good phaco machines to ensure the rock hard anterior chamber stability in dealing with this type of cataracts. We have to divide each and every nucleus in multiple smaller pieces. They should not attach with each other, and then only we have to start emulsification. The second video is demonstrating how we can use the help of femtolaser to deal this type of hard cataracts. So in this video, we can use the femtolaser to emulsify the nucleus pre-operatively before emulsification with the machine, and then reduce the phaco energy required. Again, one of the very hard cataracts, grade 6 cataracts. This we can deal with phaco chop techniques and with better microscope and good phaco machines. Another patient with very hard cataracts, but with patience and good phaco techniques, we can deal all this type of cataracts. These are the hard cataracts in normal patients, but there are few situations like very small pupil, small or very small pupil. Here, semi-dilated pupil having very hard cataracts. What are the difficulties which we can encounter in this type of cataracts? Like visualization for doing capsular axis is very difficult. Visualization during removal of cortex and phaco fragments is also very difficult. Chances of iris shaping, iris trauma is also very difficult. Once you will cut the pupillary margin or iris tissue in phaco tip, every time it will attract towards the phaco tip. So these are really, really difficult cases which need a lot of patience and skill to operate. But we can very well do this type of cataract surgeries. We need many things to take care. Like if you are operating for a small pupil cataract surgery, whether it is hard cataract or soft cataract, we should be in the central pupillary area. Our phaco tip should always remain in the central pupillary area. and we have to do phacosurgery. So these are the more difficult cases, and the hard cataract which make them much more difficult. The another is Morgagnian cataracts. This is also a very difficult condition where doing capsular axis and emulsifying the cataract is much more difficult. Here, after doing capsular, starting capsular axis, we have to inject viscoelastic in the bag to make the capsular bag taut, and then to complete the capsular axis. Here, capsular axis is really a difficult task in Morgagnian cataracts. After completing the capsular axis, I started doing chopping the nucleus, sculpting the nucleus, but it is very difficult to hold the nucleus. And I feel that this bag is unstable. So I injected endocapsular ring here. And after injecting the endocapsular ring in the bag, I completed the phaco emulsification. The same chopping is done. But these are real difficult cases, and we need good machines to have the better chamber stability. First, divide the nucleus into multiple small fragments and then complete the surgery. The next comes this type of patients which are lens-reduced glaucoma, very hard cataract inside, and fibrosed capsule. It is very difficult to do capsular axis. We have to do capsulotomy with the help of sometimes with the scissors. We have to make some side port incision to complete the capsulotomy, because these are very, very difficult anterior capsule fibrosed patients. Here, I used one more small side port, and then we should, if needed, we have to convert. We have to convert the case to SICS, and then we can finalize and implant the intraocular lens. This is how I have converted it to SICS, to few sutures, and completed the case in the calcified capsule in hard cataract. There are few situations where we may have iris coloboma. In these situations also, it is really a difficult task to do very hard cataracts, because at 6 o'clock position, many of the times the zonules are weak, and there may not be the zonules, and chances of vitreous prolapse as well as fluid going in the posterior segment in the vitreous cavity is much more higher. So sometimes we have to use endocapsular ring before starting the phacoemulsification technique. So these are also really challenging patients to complete the phacoemulsification. This is one more difficult scenario here. It is very hard cataract inside, but looks soft, hypermature white cataract. And once we do capsular axis and a single nick in the anterior capsule and Argentine flake sign. So here also we have to complete the capsulotomy with the help of scissors, and we can, with some precautions, we can go ahead and complete the phacoemulsification. The important tip here is, once you start doing phacoemulsification, don't come out of the anterior chamber suddenly. If the anterior chamber will collapse, the chances of extension of this capsular axis will be very high. So always try to keep entry chamber maintained. It should not be collapsed anytime during phacoemulsification or during IA. And even with this type of complicated, difficult situations, we can complete phacoemulsifications. This is another situation where the patient is having nystagmoid movement and hard cataract. Again, these are the difficult situations. Here, the capsular axis is very difficult. Most difficult part in this type of cases is doing capsular axis. So we can reduce these movements with the help of Sinski hook, which we use in the side port incision, and we can slightly reduce the movements. But with this movement also, we can continue and we can complete the phacoemulsification. This is how we can slightly reduce by holding with the help of one tooth forceps. But these are real challenging cases for all of us. We can use capsular axis forceps. Capsular axis forceps is a better tool for capsular axis in this type of cases. Once the capsular axis is done, then this hard nuclear core is removed and the lens is implanted. Many patients are having abnormal hand movements, head movements. In this type of patients, this is also the difficult situations for normal cataracts. If the patient is having hard cataract, this increases the difficulty for all of us. This is my assistant is holding the head. It's still, you can see how the patient's head is moving, and we have to complete the cataract surgery. This is the patient's movement, very difficult. This Cori movement of a patient is, these are real difficult patient. Even holding the head, give a lot of movement during surgery. This is that patient which I was discussing. Patient is having kyphosis, and it was very difficult for us to make him lie down. This is my last patient. We tried that this patient we can make with the help of pillows, bed sheets, so that we can make him his head parallel, but it was very difficult. It was very difficult. We tried that we can keep this his foot on the stool. This trial was failed. So what we did, we asked our assistant to hold the foot of that patient on his shoulder, and then he lifted his back so that we can make the patient's head parallel. And I sit on lower temporal quadrant, and then I started doing surgery. This is the upper lid which is hanging over the cornea. It was very difficult to sit on the lower temporal side and to operate. But with the help of all our assistants, it was possible to conclude the complete the surgery. So these are real difficult situations in our life to manage this type of patients. but with surgical skills, confidence, and God's help and blessings, we can even try and we can do this type of cataract surgeries also. The next day, patient was so happy. We did the other eye surgery on next day. It was very difficult to give position and to hold the whole body of the patients properly and did the surgery. So thank you very much.
Thank you, Dr. Agarwal, for that wonderful exposition. You have really made, especially the last case, look so simple in your hands with your modified technique. I see the president, Dr. Harvansh Lal, joining. Sir, are you there? I would like you to give some opening remarks, and then we have.
I think I'll talk about this heart cataract only. First of all, I think a wonderful demonstration of the technique and a very good bouquet of the surgeries OP has demonstrated. Just 2-3 observations which I will like to make. Of course, whenever there is a body position, is always the nodding head, nodding eye, the position is difficult, which we need to make comfortable. But so far as the surgical skill is concerned, besides the heart cataract, I say what is you can call as a difficulty score. That means the how difficult surgery is going to be. It also depends upon how well dilated is pupil, how good how deep chamber is, and how hard the cataract is, what is endothelial cell count. So you can handle one difficulty, but whenever there is more than one situation is there, you should be very careful. Like in these cases, only one comment, I have not seen him using any Malvin ring or the Bhattacharya ring, which I think should be used more frequently when you have got a heart cataract and the pupil size is less than 5 millimeter. Because anything going wrong, you will really land up into the trouble. Particularly, these may be floppy iris and the pupil keeps on becoming smaller and smaller over a period of time. And so in all the heart cataracts, starting from the incision, I will not like to make corneal incision. It should be a little limber so that it can withstand the wound bond better. Ask the assistant to keep on looking at the wound. If there's anything happening there, should inform you because you are focusing into the center of the eye. You cannot see the wound yourself. And keep your handpiece rested onto the sclera. Don't lift it up, which is our tendency. So there's more chances of wound bond. Rexus, I will definitely like to have more than 5 millimeter, at least 5.5 millimeter. And in all these cases, I do not do hydrodissection at all to start with, because I prefer to do a stop and chop, particularly if the chamber is shallow. I want to have a little more space in the eye and to cause less stress on the granules. So 80 to 90% of the trenching, I do a wide trench initially. And then if need be, I do the hydrodissection after completing, because if you do the hydrodissection, you want to trench it, the chances of nucleus keep on rotating because you are trying to use too much of energy. So that can help. And viscoat should be used more frequently and more commonly in these patients. Even in the loose nucleus, which was there, hypermogren and mature cataract, you can actually fill up the bag with the viscoat, which can give a little more stability to the nucleus. And that is the one indication where you can go for the direct chop. But overall, excellent presentation, OP. And
thank you, sir.
I think we need to use the rings and hooks a little more in these cases. Thank you very much. And I see there are a lot of galaxy of the speakers and very good surgeons are there. And it is going to be really very useful for the people who are watching it. And definitely it has time has come that everybody, the type of equipments now we have actually, if you see the type of echo machines, the type of operating microscopes, all those things have made the surgery comparatively much more easier.
Yeah.
In simple cases, most of the residents actually learn during their post-graduationship itself. So now the time has come where we have got to raise the bar and we need to handle very difficult situation as demonstrated by the OP and the other speakers are going to talk about it. Thank you very much.
Mandir, over to you.
Thank you for excellent presentation, OP sir.
Thank you.
Now I would invite our next speaker, Dr. Bhasin sir.
Can I add a comment? it is okay.
Sure,
Yes,
ma'am.
Anna.
Sure. Please go ahead.
Yeah. Excellent presentation, Dr. OP sir.
Thank you, madam.
Beautiful bouquet of surgeries. So I just had one or two just points. One is in these very hard dense cataracts, we know that the phaco power and energy is more. So it is probably better to do a specular microscopy, biomicroscopy in these cases. Also, when you are using the phaco tip, it's probably better to use a fresh tip, new tip, so that the cutting efficiency is
Yes.
more, and use
Yes.
2.8 instead of 2.2. So that it can be more easily phacoed rather than
Yes. Yes.
in longer
Definitely.
time. So
Definitely.
just a few points, and usually if it's a very, very dense hard, so we counsel the patient that we might have to convert to an SICS, or you
Yes.
might keep a retina surgeon standby, an iris
Yeah.
claw, or a 3-piece standby. And especially if the patient is wanting a multifocal or a toric multifocal, so we need to give them a little counseling that we might have to change the lens if at all there is some event on table. These were just 2 cents. Thank you.
Yes, sure. Thank you.
Thank you. Can you hear me all, please?
Yes,
Yes,
correct.
And is my screen also visible, sir?
Yes, we are
Yes,
able to
thank
see
you.
your desktop. So you can just start.
Yeah. At the outset, I would like to thank Dr. Harbansh Lal, President AIOS, Secretary Dr. Santosh, Dr. Manoj Mathur, and all the galaxy of stars and present over there. And it is my proud privilege to present my talk on phaco-emulsification in small pupil with or without pupil expander devices. So indeed, performing phaco in small pupil is a challenge.
Basin sir, your slides are not visible.
Slides are not visible.
Your desktop screen is visible.
Can you just stop and reshare actually?
Yeah, I will check it. One second, I'm sorry for the interruption. So, one. Is it okay now?
Yes, sir.
Yeah.
You can
Yeah, now visible.
You can
Is it-
slide show.
Is it the
Yeah,
first
now visible, sir. Now visible.
and the next slide is also. Yeah. So phaco in small pupil is indeed challenging, and various complications can occur during the surgery, like trauma to the iris, and we can have incomplete capsular access. Chances of PC rupture are very high, and loss of vitreous is as high as 70%. We can have dropped lens, dropped nucleus pieces, or dropped IOL. Retained cortexes could be there, which is present underneath the iris in the fornices, and we can have a dislocated IOL. More commonly, we see the corneal decompensation if there is a hard cataract along with, and chances of macular edema if these all any complication of PC rent is there. So at the end, the patient will have a decreased post-operative vision. And due to all this, a small pupil is sometimes a factor forcing not to proceed with phaco-emulsification. As Dr. Advance has already said, that if more than 2 odd conditions are there, then it is not wise, and we should always inform our patients that it is risky and we should be prepared for a plan B along with. In my opinion, small pupil cases, one can do it with experience. And we see that there are, I have differentiated into some 3 or 4 types of 3 types of cases. Like one is the rigid myotic non-dilating pupil, which we see in cases of diabetics or in patients who use myotics. Now they are not using it. Earlier, patient used to use pilocarpine. Then in the cases of pseudo exfoliation also we see that the pupil is rigid because of the dilator pupil atrophy, muscle atrophy. And less commonly it is seen amongst cases of Horner syndrome, which is rarely seen, and in the cases of dilator atrophy. Or these cases can be non-dilating due to the presence of posterior synechia, ring synechia, or presence of the inflammatory membrane. Or in cases of intraoperative floppy iris syndrome, IFIS. So the matter is whether the pupil size is more than or equal to 5 millimeter. If it is more than or equal to 5 millimeter, with experience, you can definitely proceed with the case. And in between, if you find that the pupil is further gone down, or you have once held the iris, which is going to be floppy after that, and it is going to come to the tip of the phaco again and again after that, then you can very carefully, without involving the capsular access margin, you can use iris retractor or pupil expanding devices in between the surgery also. But more or less, you can complete the case if it is more than or equal to 5 millimeter. But if it is less than 5 millimeter, then I will say that we should use the instruments or the things like iris hooks or the pupil expander devices to facilitate the surgery and to make it safe. Our surgery should be immaculate. The wound should be very well constructed as per the size of our phaco tip and our side port incisions, what type of chopper you are using, and whether it is a sharp chopper. So according to the size of so that there is no wound leak. If there is, because more commonly the wound leak can lead to the iris, which will come further towards the wounds, and the pupil size will further cut down. Use trypan blue dye to visualize the capsule in all the cases, and low parameters are definitely helpful. And in cases of shallow anterior chamber, we should always use viscoelastic like high viscosity and Healon 5 or Healon GV kind of viscoelastic in all these cases. Otherwise, also it helps in dilating the pupil because of these heavy viscoelastics, and they protect the endothelium also during the surgery. So if it is less than 5 millimeter, use iris retractors, maybe 4, 5, or 6 in a diamond pattern, or one can use pupil expander devices like Malugan ring or BX ring or other rings which are also available. So this is my first case of a uveitic cataract, and which has a fibrinous membrane with a small pupil. We go through the side port, fill the chamber with the air bubble, which I usually have in front in the syringe itself, and I go underneath the iris and push the trypan blue dye, and with this Havana scissor I am making small licks, but they are not large enough to increase the size of the pupil, and this pupillary membrane, which is the cause for the pupil not to dilate, is released. It is removed, and then this small trivial bleeding will indeed stop immediately, and pupil stretching is done, and you see the size of the pupil is now almost 5.5 millimeter or 6 millimeter, and we can easily perform phaco in such case. Another similar case, small pupil. This was a case which had iris Bombay, so we did a YAG PI, multiple YAG PI to decrease the iris Bombay, and the anterior chamber is very shallow. Same way, we go underneath the iris, push the trypan blue, fill the chamber with air first, and release the adhesions and the membrane through the pupil. There is a chances of damage to the sphincter muscle, but because in such inflamed eyes, the iris is also little traumatized due to the inflammation, because the patient was having the iris Bombay. And then, as you see, pupil stretch will help us to some extent in all these cases. As I have seen that in very many cases, when we use iris retractor in these cases, which are where the iris is not that healthy, the chances of damage to the sphincters are there after removal of the iris hooks, and even after the Malyugin rim we see. So phaco can be done easily, and you can use hydrophobic acrylic IOL, and this is how we finish the case. So coming to the other pupil expander devices, like this is another case with the pupillary membrane. I'm using Utrata forceps here. I've not made any nicks with the venous scissor or micro venous scissor. Pupil is really very small, and I have not tried the pupil stretching, and used 4 iris hooks. I'm comfortable with 4 iris hooks and make a quadrilateral kind of a thing. Another case, and we finish the case with the phacoemulsification once the iris is pupil is dilated. This is a Malyugin ring. This can be injected with the newer Malyugin ring through the 2.2 millimeter incision. Earlier, we used to make a 2.8 millimeter incision only, but nowadays we can do it, insert this ring through a 2.2 millimeter, and we get a fairly large pupil size, and we can complete the phacoemulsification. Another case, this is a wonderful ring which I bought it from when I went to ESCRS. This is from the Oasis company. This is made up of PMMA. It is a bit bulky, I agree, but the pupil size which we get is amazing, almost 7.5 millimeter pupil size, and like a normal dilated pupil, and you can use it in repeat use it and do the phacoemulsification. And this is a B-hex ring, our own Bhattacharjy's ring, which comes with the forceps. You place it in the anterior chamber in the pupillary margin, and these loops are there, which are passed in a similar way at the pupillary margin at the iris, through the iris, and you have to go through the side port. You have to keep it in mind that throughout, while using all these pupil expander devices, you have to keep the anterior chamber filled with viscoelastic. If it is leaked, you push it again, because otherwise you are going to damage the iris or the corneal endothelium. That is very, very important. So, friends, these are necessary things, but nowadays we are doing, even without pupil expander devices, even in 5 millimeter or less than 5 millimeter pupil size, one can do with experience. And definitely surgery presents several challenges. But I'm showing you this unedited video, which is of the size of 4 millimeter or in between. After the hydrodissection, the pupil size became 3 millimeter or so. A capsular axis is guided by the pupillary margin, and you complete it. One can use Utrata forceps, that is the personal choice. I've used the viscoelastic throughout. One can use a heel-on, but I've used the simple methyl cellulose. Now, this is a good thing is that this is a grade 2 nucleus, and what we have to do is our working zone is just 3 millimeter, and in this working zone, we work and we hold the nucleus and pull it towards the center and then chop it, as you can see here. And make small pieces and chop it, and this is how, and it is pulled towards the center, and then you don't have to hunt or go behind the nucleus pieces, otherwise you are going to hold the iris and the pupillary margin. And our plane of working should be just below the iris plane. You work, and this way the pupil will not be damaged, the iris will never be damaged, and secondly, the endothelium is also not affected or damaged with this. And with the newer machines where the chamber stability is very good, you can rely on the machine, and because the followability is also very good, so that helps in the success of this all these cases. My wound size is non-leaking. As you can see, there is no leak from both the wounds, and that is very important thing. And the epinucleus is being removed now. And this is totally unedited video, and it is at the normal speed which we use. And this is how things are coming. The followability is so good that things are coming to the tip because of the good the flow. And then we do the cortex removal, and we can use a second instrument, or with the help of our irrigations port, we can check it. We can go laterally and check and push the iris towards the periphery and see that if there is any piece of cortex there under the iris, and then a lens is placed in the bag. So sometimes the nucleus, the cortex pieces, they are left over behind the iris or in the angle of the anterior chamber. So you should flush it at the end of the surgery. This is the end of the surgery. Wound size should be good. So phaco is possible by any experienced phaco surgeon without the pupil expansion devices, unless there is a hard cataract, very shallow anterior chamber, the cornea is compromised, or zonules are compromised, or there are fibrosed anterior capsule. These are all variety of cases with a small pupil, which we have done it, and without using any pupil expanding devices. To summarize, pupil expander devices definitely enhances the safety, and I will recommend in all the cases and for all the new surgeons and all the surgeons who want a safety, or in premium cases, definitely we should use it. Address the cause. Plan according to the condition, what the case is. Maybe we can use a pharmacological mediators to begin with. Pupil stretching by to Kuglin hook or to Lester hook, or maybe we can use the iris retractors or the number of rings which are available in the market, and that is really going to facilitate the surgery. And peeling of the inflammatory membrane is my technique, as what I do it, and I feel that that is also very helpful. I thank you for your patient hearing. Thank you, sir.
Thank you, sir, for wonderful presentation. And the last case without any pupil expansion device was really something to see. It's not for beginners, and even for advanced surgeon, I feel it's always safer for patient safety to use pupillary expansion devices. One thing I would like to ask, when do you prefer iris hooks and when do you prefer rings? I mean, is there any particular case where iris hooks are preferable?
When the iris is traumatized, then I will prefer a ring that is much more useful in such cases. Otherwise, it all depends because the expander devices, the rings are expensive. Malukin ring is expensive, so that's why I more commonly use iris hooks. And if patient pays, then we use a Malukin ring in these cases. But if the iris is traumatized, I will definitely prefer using the BX ring or the Malukin ring.
One is that whenever you are trying to put the Malukin ring or the iris hook, because you are trying to put between the iris and a capsule, so some amount of viscoelastic should be injected between the two. If you fill the chamber, the iris gets compressed against the capsule. And this is even more important. If you have started this surgery and in the middle of the surgery, you are going to put the ring or the hooks, it is very important to put the viscoelastic between the iris and the anterior capsule. Only if you take the indication wise, in a very small pupil and its closed pupil of say 2 millimeter or so, the ring may be little difficult to place if you are not experienced, because you have got to use the bi-manual technique. That means after putting the first and a second scroll, you will have to pull the iris and then put the ring. So in those cases, the beginner can use the iris hook. Thirdly, the aim of the many times when you use the iris hook and you make a quadrangle, you will see the shaping of the sphincter closer to the incision. So to avoid that, you need to make trapezoid. That means the hooks closer to the incision should be closer to each other, and the pupillary border should go under the internal lip of the incision. If the pupillary border goes under the internal lip of the incision, there will be no rubbing of the phaco probe onto the sphincter. And same way, if by any chance your iris starts collapsing, your aim is whether from the side port or from the main port. Put two hooks and bring the pupillary border peripheral to the internal one. Then it won't keep on coming. So these are just few tips. Otherwise, excellent presentation. And the Malvin ring can be reused at least 5 to 7 times without any problem, if you take care how to take them out and if you have got an ATO system in place.
Yeah.
Amit sir.
So, excellent presentation, Basin sir. Only a few remarks. Overseas iris expander is available in India by Precon Surgicals. He is selling the overseas iris expander. And what protocol I follow basically with handling small pupil is first do using intracameral medications. You try to dilate the pupil. Then next step is intraoperatively. You can use viscometriasis. If that fails, if there's any synecholysis, doing osseous membranectomy, which you demonstrated, is very, very important. The surgeon has to identify whether the small pupil is because of a membrane, syneche, or a rigid pupil. This identification is very, very important. Quite a few times, what happens, people don't know about this membranectomy and they just try to tear away the iris. And regarding the question whether when you use iris hook or when you use an iris expander, I personally feel I've given up using iris hook for more than almost 13 years now because of the multiple limbal stab wounds which we create. And if it is a rigid pupil, the Malugin ring or the OXC iris expander, they work well. If the pupil is not so rigid, then BX works very well. And this all comes out to be very economical, as Harvansh said. If you have an ETO, you can reuse all this expansion device at least 4 to 5 times. And if you're not using any of this expansion device, stay in the safer, safe zone in the center. You can do a direct chop. And very important is at the end of the surgery, after you have injected the IOL, try to collapse the AC a bit. So what happens is any loose cortex which is stuck in the sulcus and all that just escapes out into the antechamber. And as you have said, you just flush it a bit and the loose pieces which are there, they might pop out. So to avoid post-operatively seeing small nuclear pieces, it is better to do this technique so that we can identify if any pieces there. That are my viewpoints. Thank you.
So, Sheila.
Thank you, Dr. Manoj. First of all, I think Dr. Basi, excellent presentation. I want to steal it. It had everything in it that you need, including a case where you didn't use any expansion devices. So that was wonderful. I think that Amit is an experienced surgeon, so he's stopped using iris hooks. But I would agree with Manveer and with Dr. Harvansh that first step is to know how to use iris hooks very well, because they are your first bailout technique. And sometimes the pupil goes down intraoperatively, so you can use iris hooks at that point also to improve the safety of your surgery. So exactly as you mentioned, that iris hooks first, and then you need a little bit more practice and a little expertise to use the rings, any of the rings. And the indications of each of the rings you have covered beautifully, and so has Amit. So nothing more to be said, except that don't discard the iris hooks. I think there should be the #1 step that everybody should know how to do.
And one more help the iris hooks can give is in case of a weak capsular bag, you can use these iris hooks to stabilize the capsule also.
Never use an iris hooks to stabilize the capsular bag. Always use a capsular hooks.
Two hooks are there.
Never use iris hooks.
And if capsular hooks are not available, then iris hooks.
No,
they'll traumatize the capsule.
No, but if they are not available in OT at that time with the surgeon.
Yes.
Anika, you.
Yeah. So lovely presentation, Dr. Vasim sir. So just a few points. Many times you have a very small pupil, and when you try to put in a BX ring, or a Malugan, it is more difficult, like Sir said. So in that case, if you do just a limited pupillary stretching first, bring it to at least around 4 millimeters and then put it, then it is little easier. And when we are doing a pupillary stretching, nowadays we probably avoid pupillary stretching from limbus to limbus because it really tears the sphincter. So it could be a little limited one and very, very gentle, so that at the end of it, you can have an aesthetic pupil. And many times in these small pupils, we have also done multifocal IOLs. So BX we have found is very gentle, and because it has a very thin profile, it is more gentle on the iris. So in such cases, I would prefer to put in a BX. And when you're putting in iris hooks, many times it's important to know where to take the stab incisions. If you take it too anteriorly, it can cause tenting up of the iris towards the cornea. If it is too posterior, then it can cause bunching up towards the wound. And when you are taking, in case of an IFIS, you should calibrate and have a smaller side port rather than a usual side port, because we don't want that to leak, or it can cause iris prolapse towards the side ports also. Just those few points. Thank you.
Really nice tips you have highlighted. I will agree that we should use the rings with caution and care. And I always go stepwise. And because sometimes I have seen that the pupil is not dilated because the dilating drop has not been used. So I always use intracameral mydriatic and try to use it. Then with the help of viscoelastic, we try to see if it is 5 millimeter or slightly more than that, then we go ahead directly without using any assistant device, because then you can finish the case faster. And this is really very good. Dr. Vanati?
Yes, Dr. Purendran. I think to add on to this already comprehensive discussion, just a few points is that already reiterated by some of the earlier speakers as well. Iris hooks still is something which works in almost all scenarios. And just remember to move your incision a little posterior when you're placing your iris hooks here through your side ports. And I use 5 hooks instead of 4. And that really avoids the tenting in the subincisional region and gives you a very wide. So it's one of the cheapest, it's the easiest, it's the fastest. But then when you do have your other rings and pupil expansion devices, again, for the question where you use the rings and where you use the expansion devices, the classical teaching lies in that where you want to use your expansion rings is where you do have a certain amount of dilatation when the pupil, when you're starting your surgeries. Like in a floppy iris, it does dilate in the initial phase, but your dilatation does not retain through the surgery. It starts constricting. So in such cases is where a pupil expansion device is required. And where you really do not dilate, you have rigid pupils, you have bound down pupils, and you have myotic pupils in extremes of ages, then you probably would want to go ahead and use an expansion, a full ring to cause a greater exposure during your surgery.
Yeah, thank you, sir. And Dr. Bhasin, sir, again, a beautiful presentation. I think we have discussed almost all the points. One thing that I'll probably say is that this happens also sometimes, that you begin the surgery, you probably don't expect the pupil to come down, but sometimes you have intraoperative IFIS and the pupil starts to come down, you are really not prepared with the ring. But in these cases, if you are actually going with hooks, you have to be very careful because you already have the rexus and you don't want to rip it off. So one thing that one can do is, instead of going all the way to, let's say, periphery, actually such iris hooks can also be used in moderate fashion. So you can actually open the pupil only to 6 millimeters so that you are actually making sure that the pupil, the rexus is not caught. Make sure that you use plenty of viscoelastic between your capsule and also your iris. And of course, I think the point about using the 5-point fixation of hooks works very well, especially if you have IFIS, because if there is a case of IFIS, if you use the diamond shaped just behind your main incision, the chance of your main iris to prolapse out from the main wound is going to be quite significantly lower. And you can also use high density viscoelastics in these cases to have a good amount of viscometriasis and also keep the iris away from the prolapse in the periphery of the wound at the at both the side ports also and also at the main incision. What I find also is that if you have a very shallow AC, sometimes putting the pupillary expansion devices becomes more challenging. So I think if you have a very shallow AC, iris hooks becomes probably a preferred choice for me. But I think otherwise all the points were discussed so far very well. Thank you. Yeah.
Thank you.
We move on to the next talk by Dr. Prerna Upadhyaya. She will be speaking on Toric IOLs. You can start sharing your screen now.
Good evening, everyone. I've chosen this topic on this platform because not routine toric, but in a special situation because so many eminent surgeons are here. And always we remain in dilemma as a corneal person because getting so many cases with high astigmatism other than senile cataracts. I am thankful for whole AIOS scientific committee for giving me this wonderful chance. Prevalence of corneal astigmatism is more than 5 diopter in 1% of the patients. Options available are various, but Toric IOL is the gold standard in these situations. Like any other cataract patient, they also need good refractive correction, and they constitute a large percentage of patients. Instruments should be used for measuring various, but we should require IOL master and tomographer like thing for doing these difficult cases. Different types of toric IOLs are available like monofocal toric, adopt toric, multifocal toric in different materials and designs. Apart from senile cataract of more than 1 diopter astigmatism, pediatric cataract, non-progressive actatic disorders, post-RK, post-DAL, post-PK patients, as well as pediatric patients. Marking should be done in an upright position because to avoid cyclorotation in the supine position by any means. For successful surgery, should do good phaco, remove all the viscoelastic and tapping of IOL after completion of the surgery. Most common mistakes, people which gives bad results due to incorrect data entry, improper alignment, and marking errors. Postoperative outcomes depends upon the material design, CCC size, IOL coverage, proper sealing of the wound, as well as experience of the surgeon. We all know astigmaticfix.com. If there is fall short of an axis, we can rotate it anytime after 2 to 3 weeks of the surgery. Nowadays, strict contraindications are uveitis, uncontrolled glaucoma, corneal dystrophies, progressive ectasia, zonular instability, and post-PR surgery. So this is my first case in which astigmatism of 3 diopters, and this is a 16-year-old boy with unilateral developmental cataract. It is usually bilateral, but in this, in other eye, he is having only blue dot cataract. So we try to give him full correction and choose adopt toric for this patients because he needs good intermediate vision also for his computer work. After doing particular surgery, this IOL is implanted. This is single piece toric IOL with some intermediate vision. This is actually advanced monofocal. Main is and outcome was very good. Dr. Jagatram also did a study between 8 to 14 years of children, and they find it is suitable even for this age group. This is our second case in which we found this is post-RK case, where astigmatism is very high. We calculated it by different means and found consensus between this Barrett calculator as well as in other methods, and decided to put this toric IOL in post-RK patients. Not doing routinely, but this patient is having quite hard cataract with 16 RK marks, and she's a working lady of around 50 years, and needs good vision because she is still in service and very difficult for her to do her work. And main thing is that you should do calculation with different modalities. And if astigmatism is not very irregular on pentacam and consensus in different types of measurements, different types of equipments, you can put Toric IOL. This is customized Toric. This is actually very easy to put. Always they advise to put you at 180 degrees, 180 degree. And rotational stability of this IOL is very good. I have no commercial interest, but for these patients needs customized lenses only because of high cylinder power. And there are various studies people are doing after RK also, and these case reports also, presentations also. This is again, this is our third case. This is post-DAL case. This is also a young boy operated for this corneal scar that was done 4-5 years back. Now he's having 4 diopter cylinder with significant cataract. This is also unilateral case and young patient, so need better correction. So in this patient also I decided, because talc is very safe, I think rejection chances are very less here. Only thing is that you have to remove sutures around 2 months before and allow the astigmatism to get stabilized. And take care of the graft post junction as well as endothelium for doing such cases. Do specular beforehand. Everything, actually, it makes no difference whether you're putting monofocal or toric. But toric gives them better vision and they remain more satisfied, because it is very impractical to give them 4-5 diopter cylinder in one eye. That is usually not accepted by the patient. And contact lens is not very easy for them to use. The type of patients we are dealing more from the periphery. Although in such cases, results are not always refraction. Sometimes refractive error is there, 0.5 diopter, 0.75, but still patients are happy patients than monofocal lenses. This is a single piece toric acrylic lens which we have chosen. The IOL type depends upon the patient's affordability as well as their astigmatism also. We are not doing in all cases, but yes, in selective cases, they require this type of surgery. Here again, there are various studies where people have done these type of lenses after DALC and this is our fourth case in which this is more typical. Patient is having 8.5 diopter of cylinder and lot of corneal scarring, but surface is not that irregular. Ocular surface is not dry, so we selected to put toric IOL in this patient because both the eyes similar and vision is very less. But ultimately, this patient is the happiest patient. Case looks messy. And this is a fifth case in which, again, controversial. Patient is having 7 diopters myopia with 5 diopters cylinder. Again, relatively younger patient. And here, people are saying bag is big, so rotational and stability chances are more. So that's why usually we won't go, but patient demanding, and we have chosen to put a toric, and there is no rotation after the surgery, 6 months follow-up, and the patient is again. This is our 6th case, and this is actually post collagen cross-linking keratoconus patient, which is collagen cross-linking was done long back, I think 5-6 years back, and he was using contact lens, but now developed cataract. So we decided to put, because in other eye he is still using contact lens, so we decided to put toric IOL in this case. And residual diffraction is perfect. Patient again 6-6 vision. So main thing is that consult the patient, explain them that there are chances of residual refractive error. But mostly patients, these toric IOLs always gives wow feeling to your patients, very forgiving, no additional learning curve is required, very affordable, and calculation is very easy. Because so many, I am not telling it toric for all, but in selective patients, I think we should do toric, and patients always remain happy. Thank you.
Thank you, ma'am, for wonderful presentation and for showing variety of cases where toric lenses are very helpful post-DAL, post-RK eyes. And these patients who have underwent refractive surgery of any kind like RK, they want basically spectacle independence as much as possible. So if we can help them with toric IOLs, I think we should all use toric in all these post-refractive eyes, because multifocal should be avoided in all these cases, but toric, since they do not cause any visual symptoms, then torics are good. Any comments from Harbans?
Basically, whenever this cornea is irregular, the refraction has to be taken into the account. Because if you see the post-RK patients, they have got so much irregular cornea, there is some point from where they are seeing perfectly all right. And this is where the spectral correction comes into the play. That means if you got an agreement on a pentacam and optical biometer, then it's okay. But if there's a disagreement, I had many patients that the pentacam is giving 172, optical biometer is giving 150, and the patient's acceptance is 165. So all the patients who have got the acceptance in irregular cornea, that is far more important than the pentacam reading and the optical biometry. Because this is where the patient is seeing well, because these patients come early, they do not have a very advanced cataract, they have got a reasonable good vision. Toric IOL is only contraindicated if there is a progressive corneal pathology or if the patient is contact lens user. That means irregular cornea, whether because of the RK or because of the keratoconus or keratoplasty, patient is using contact lens. Please do not use the toric IOL, because patient is the type of vision patient gets with the contact lens, he can never get it with the toric IOL. And if you put on a toric IOL and the patient uses the contact lens, then toricity of the eye will come into the play and you will have to prescribe the glasses. And whenever you also have seen many a times, the refraction has to be taken into the consideration even when you are correcting. Suppose patient has got 0.8 diopter of astigmatism on a pentacam and optical biometer, and if patient is using minus 1.5 cylindrical in his glasses, I will rather correct this patient for 1 diopter than leave it uncorrected. So if patient has got a refraction, patient is getting 0.8 on a pentacam and keratometer, but refraction is 0.5, I will not correct. So the patient's refraction, I have seen many patients are not corrected because of the pentacam and optical biometer reading, and then they needed glasses afterwards of around 1.25, 1.5. So the refraction is very, very critical. You should not ignore it. And you should have at least 2 equipments to cross-check it. And there should be no averaging of the readings. Biggest mistake, I think, is the dry eye. And if you treat the dry eye, because they bring the chart, Optom brings the chart, and you look into it, and you decide this is the keratometric. This is absolutely wrong. They should bring the keratometric values separately of the 5 readings. Whether if there is a more than 0.5 diopter of disagreement between the 2 readings or more than 10 degree of disagreement between the 2 readings, probably this patient is suffering from dry eye. Treat him for the dry eye and then take the reading again. And even the patient who have come from outside to the city, I did the keratometry on the first day. Next day I was going to operate. In the morning, keratometric reading was entirely different. So if you feel that there is a hashtag coming, there is any doubt, please do treat the patient for the dry eye if you want to avoid these surprises. And when you are all marking, because many times you have got a confusion, you are getting a 17 degree, you want to have a 15 or 20 or 22 or 12. So not only you should have marked the axis, you should also mark the point of error. That means I'm planning 15 degree. If I got to err, should I err on the side of 20 or should I err on the side of 10? So you should also, when you're putting a lens, you should have that in your mind with the various parameters. And all the analysis, even if I decide that this patient needs 67, because when I go to the OT, I may not realize whether I've seen all the data or not. I will write with the pen 68 or 67, something over there, so that I know that I analyze all the data. I'm in agreement with whatever I'm seeing on the biometer. So that when you reach into the OT, you don't have to see what is the pentacam reading. And so far as the posterior corneal surface is concerned, if you're taking total corneal power of the pentacam, you do not have to worry about the posterior corneal surface because it has been already taken care of. I do not agree with the Barrett formula because it takes 0.3, 0.4 diopter, considering all of them are vertically steep, which is not true. So you take the total corneal power, which is far more accurate. The power has to be calculated with the anterior corneal power. And when you are comparing the two instruments, like say pentacam and optical biometer, compare anterior with the anterior. Do not compare the total corneal power with the anterior of the optical biometer. So compare anterior with the anterior, but take the total corneal power of the pentacam, which will be far more accurate, and keep the reflection in mind. Do not use the viscoelastic methyl cellulose into the capsular bag, because under no condition you can remove the methyl cellulose completely from the bag. There will be far more chances of rotation. So either use the hyaluronic acid or do the hydroimplantation. There should be no methyl cellulose inside the bag when you leave the patient. And in these patients, you must inject the air when you withdraw, but the pressure should be from the top so that the lens gets stuck to the posterior capsule, it won't rotate. Eyes should not be left hyperinflated. If the capsular bag is inflated, I mean, if your hypo is 30, 35, there are more chances of rotation. When you try to rotate a lens in a soft eye, you won't be able to rotate. That means the pressure or the IOP of the patient, when you leave it between somewhere around 15, 14, 12, or 13, you see that it is not very hyperinflated eye. So these are a few points. I mean, there are many things. I mean, I can go on talking about the toric IOL, but these are the few points which I feel like.
Dr. Anaga?
Thank you.
Yeah, thank you. A lovely presentation, Dr. Prerna, ma'am. So I lot of cases that you have showed, really, even in the very high and irregular astigmatism, like in keratoconus, I mean, with under severe guarded prognosis, we have used not in the irregular in the sense, in the central 3 millimeters, if it is regular, you can still use the customized toric lenses also with very good results. Regarding the threshold as to when to use a toric and not, we put all patients on the Barrett toric calculator and see whether the patient needs even a low power toric like a T2. So there is no threshold like 0.75 or 1. That is what we follow. Secondly, for all toric patients, we used at least 2 readings on 2 different days so that we are sure that it is a repeatable and consistent reading. If it is not, then definitely we have to look into, like sir said, anyways, ocular surface and all that. Post-operatively, the rotation is maximum in the first few hours. So there have been recommendations even in the recent ESARS that the patient is made to lie down for 1 hour, or you can put in a pad and see that there is no immediate movement, and see the patient after 1 or 2 hours to see whether the lens is still in the same axis or not. And the moment you feel that in the few days that the lens has shifted, rotated, then you can easily do a rotation back with going through the www.astigmatismfix.com. So these are just a few points that I thought I'd add.
Amit?
Excellent points Dr. Arbet sir has told. Only few things is that it is not necessary that only if you have a cylinder of 0.7 for more than 1, you should subject the patient for Barrett toric repeater or anything. I personally felt that after I attended a meeting in APSRS, so any A scan, if you put that under the Barrett calculator, you will be surprised to get the low power torics patient is accepting. So if the patient is accepting even a low power toric, we should give that low power toric to the patient. We should offer the toricity to the patient, the toricity correction. Second thing is, so everybody doesn't have they don't have access to pentacam or anything. So like what I do is I take the manual keratometry or the automated keratometry along with the IOL master. I use a true K method of Barrett and then calculate the toric IOL power. This is very important. And as sir said, hydroimplantation is the best technique. And if you are not able to do hydroimplantation, try to learn to pass the infusion of the aspiration cannula both behind the IOL, try to wash out all the visco, and always underinflate the anterior chamber of the bag. Never overinflate, because if you overinflate, the moment the patient is in the standing position, there might be some rotation, because not every IOL has a good tachicity to adhere to the posterior capsule. So this is very important, which you have to take into consideration. And also make sure that you mark your wound. I mean, the incision size. You should know what is your SIA. Sometimes you know what is your SIA, but you might use 2.2 or 2.8. But sometimes the side port is not calibrated. The side port incision also is very, very important. These are a few things which I wanted to say.
So before we
Amit,
move
one
on,
thing only,
Dr.
if it
Harbansla,
is, so if it is a low toric power, say 0.5, 0.6, 0.7, if you are using multifocal, it makes sense to use the low toric, because multifocal will reduce the contrast, and leftover cylindrical also reduces the contrast of the patient. But we are using the monofocal lenses, then these little astigmatism actually increases the depth of focus for the patient. So while it may improve the contrast, it may improve the visibility, but the little cylinder point less than 0.75 in a monofocal, if the ultra spherical power is more, I will not like to correct less than 0.7. If I'm using multifocal AIOS lenses, I will definitely like.
Dr. Anaga? Okay.
So I spoke already, sorry. I didn't.
So before we move on with Dr. Stapek, we have got two questions in the chat box. A question from Dr. Venkateshwar, open to the entire panel. Anyone can answer. Cataract with fluid vitreous, any precautions to be taken?
What is the question?
Cataract with fluid vitreous, what are the precautions to be taken?
Not getting cataract with the fluid vitreous.
Fluid vitreous, yeah. Any specific precautions to be taken?
No, I don't think we need to take any special precaution for that.
What do you mean by fluid vitreous actually? I mean, any specific question?
No,
You can again go to the chat box. What do you mean by fluid vitreous? I mean, high myope will
Does he mean high myope?
He has written just fluid
yeah,
vitreous, probably high myope, where we are anticipating a fluid vitreous. Any specific precautions?
Nothing, I don't think.
So,
I think in a
There
fluid.
could be the, the retropulsion of the iris lens diaphragm. So maybe in such cases, when you put in the irrigation or the phaco probe, then with the left hand with the Sinskey hook, you can just lift up the pupillary edge so that you don't have sudden, expansion of the anterior chamber. That is one precaution you can take.
Secondly, high myopes, actually you can use the low bottle heights because the fluid inside the chamber is good enough for any surge. The chamber, because there is so much of a deep chamber, even if the bottle height is low, there's enough of fluid for the surge. So you don't have to really have a very high bottle height in high myopes, because of them, they may have a little more general stretch and silly discomfort. So comparatively, you can use the low bottle height. So
again, wound reconstruction is very important. You should not use a long tunnel, because if you use a long tunnel, then you'll have corneal force and visibility will be hampered. So the length of the tunnel should be very small when you're doing the case in high myopes.
Yeah, and then high myopes are basically because the posterior vitreous cushion support is lost because of the degenerated vitreous. You would have a deeper anterior chamber most of the time, even with your normal phaco settings or your fluid phaco fluid dynamics here. So that's perhaps what Dr. Venkateshwar is asking here. So you would probably have sometimes visibility problems when your iris diaphragm bag complex moves a little more posterior here. So that might give a little difficulty, especially if you're doing hard cataracts, and if your zonular support is not good enough and your zonulopathy is a mild zonulopathy is there, you will not have to use too much of stress in these patients, which might induce a zonular dehiscence in these patients.
In these patients, you can also do the supracapsular phacoemulsification. That means you collapse the nucleus into the anterior chamber, because the chamber is very deep and you are far away from the cornea, so that you don't have to keep on going too far posteriorly. So many times these patients do the hydro, everything comes out, let them come out. Don't try to push them back into the bag.
Next question is from Dr.
So Dr. Manoj Mathur, may I take the lead now? Thank you very much for including me into this discussion.
Thank you, Dr. Harbansla, for your wonderful inputs for all the talks as of now. We are indeed blessed to have you on our program today.
Okay, thank you. Thank you.
The next question is from Dr. Sugato. How do you ensure that a small nuclear fragment is not hiding behind the iris in a small pupil? Dr. Puren, would you like to go ahead? Dr. Puren or anybody else?
Okay.
Okay, traveling.
Yeah. Actually, I'm
no
left
problem.
and I'm now on mobile. Not an
Yeah.
issue. The thing is that if we have to flush it with our irrigation cannula. With this irrigation cannula, you flush underneath the iris and in the fornices and check it if there is any leftover epinucleus piece or some nucleus fragment is there. Because mainly in small pupil and otherwise in hard cataracts, when the bulk nucleus or the lens is there, so these small pieces of nucleus or epinucleus definitely they leave behind and they can cause inflammation in the post-operative period. So you have to be very, very careful and you check the surface of the iris, because if there is any piece which is large enough, big enough, then the iris will bulge and the anterior chamber will get shallow, and that is how I do it. And otherwise there is no way. You have to keep it in mind when you do such bulky lenses or small pupil cases.
Especially in flax, when you do also, make small cubes, then it's more likely to get hide under the iris.
True. It is mainly in the cases where the nucleus or the lens is big enough. In hard cataracts, in brown cataracts, you see that you are left over with pieces very often, and you have to be very careful in at the end of the surgery. That is what I just see that in such cases you should be very, very careful.
Then there is a general question. Adenoviral epidemic conjunctivitis period, cataract camps should be conducted or not? Any Government of India guidelines? Vanati, do you know anything about this?
I think it's always understood that when you're having an epidemic in surface infection, you would not want to do anything which would actually get a lot of people together, because it's an infectious condition here. So I think it's better to wait till the epidemic situation sort of settles down before you want to hold a camp. I'm not aware of any Government of India guidelines as such, but it is yes, Amit.
So in Indore and around, some of the DPMs have taken this stand that no camps should be conducted for next 2 weeks. Today, somebody was telling me in Chhattisgarh, they are told not to perform any paid or camp surgeries. And if you are performing under high risk conditions, you have to inform the patient and then perform. So it is again, I think there are no such guidelines, but it's an individual decision what you have to take. Your pros and cons, you have to take your own decisions.
I think it's a clear understanding when you're having a surface infection which is spreading as an epidemic, you would not want to do a camp.
There are a couple of other questions also. Dr. Kashyap is asking anybody who is marking the IOL in the central part, Toric IOLs, I think. He's asking if anyone marks the Toric IOL in the central part.
So basically this question Dr. Kashyap is asking, I think in India, Dr. Sri Ganesh had come up with a technique. I mean, he used to indent the surface of the IOL with an indenter which he has invented. So that in case of small pupil, when we are not able to see the toric markings, this indentation which he has created on the center of the optic will help him as a guide on what axis IOL should be placed. And this indentation, what he causes with that instrument which he has manufactured or invented, that is only, it lasts for a short period of time. Then these marks disappear. So, I think he's the only one I've heard till today.
And Dr. Lalit is asking if SI ranges from 0 to 0.5, how to calculate IOL axis.
Fourth presentation is there, or I?
Yeah, that's what I was thinking. We have Dr. Pawan Sabak.
If you permit, I can leave this meeting. No problem.
Sorry, sir.
No, sir.
You
There is
can
lot of
go ahead.
questions
Your
coming.
presentation is
No,
it.
we are coming to you, Dr. Pawan. We just wanted to finish off the 3-4 questions in the chat box, and we move on with your talk now. I would like to invite Dr. Pawan Sthapak to speak on flags. Dr. Pawan, you can share your screen.
Thank you.
Yeah, you are on.
Good evening, dear friends, and thanks for giving me this opportunity. Femto laser surgery. So, as we know, femto laser provide an ultra-fast burst of energy. Femtosecond photo disturb the tissue, excimer photo ablate the tissue, and organ photo coagulate the tissue. The principle of photo disruption we all know. Laser energy is absorbed by the tissue, which result in plasma formation, and the expansion of this plasma create an cavitation bubbles, which separates the tissue plane. This is covering this. So I am doing this. Okay, it's fine. So with the help of femtosecond laser platform, we can do cataract surgery, capsulotomy, lens fragmentation, arcuate incisions, primary and secondary incisions, flap, and therapeutic applications like penetrating keratoplasty and intracorneal ring. For cataract, it used the 80 kilohertz energy, and for corneal flaps, 160 kilohertz. What do we expect of ourselves? Perfection, happiness, confidence, and professional satisfaction. For that, what does we do? Change and adopt the new technologies, offer new technologies to the patient. This is patient I recently operated. With the help of Femtosecond, we can customize our treatment. This is the picture before the treatment. This is OCT image. The diameter of capsulotomy is 5.5 millimeter. Rim height is 500 micrometers. And these are the all parameters. And you can appreciate here the completed capsulotomy. And this is real-time OCT, where we can see the capsulotomy. For lens fragmentation, this is the photo which is showing the fragmentation of the lens, and we can see here in the OCT also. For corneal incisions, we can customize our treatment. Like in this primary incision, the number of planes are 3, outer width is 2,800 micrometer, and inner width is 2,700 micrometers. We can customize the primary and the secondary incision also. This is the OP camera image after the treatment, and this is the OCT image. We can see here there is complete separation of the tissue layer. With the help of femto-anterior capsulotomy, we get precise, consistent, accurate capsulorhexis as compared to the manual ones. It is better size, more circular, better centers, thus there is less chances of lens decentration. For lens fragmentation, we can take the several patterns like spider web, circular or radial or grid type of pattern. In one study of 52 cases, phaco cases versus this femtosecond, we can see here is the effective phaco time in femto cases is much lesser than the phaco effective time. This is overlapped here. So it is almost 90% more less than the effective phaco time of the manual ones. This is another case. This is the primary incision. We can see there is very good separation of the tissue, and this is the secondary incision. We can also appreciate this in the OCT. So the introduction of flex technology, since I am doing this technique since last 5-6 years, and there is separate group of patients which opt this technology. There is a first we dock the patient. You can see here the capsular axis, and this is the real-time OCT. We can get the capsulotomy. Now this lens fragmentation is going on. This is white cataract. This is the corneal incision. We can see the primary incision. The separation of incision is very good in temporary. When the primary inject the laser separator, it is easy to enter into temporary incision. To remove the anterior already separated. This circular capsule. This cataract is already fractured, so it is easy to cracked just to remove the fragments. Need less amount of ultrasound energy. Eco-emulsification is done. This is another case of the hard cataract. Operation of the incision. With the help of the separator, we enter into the anterior chamber. Inject the viscoelastic. We separate the second incision. Move the anterior capsulotomy. There are always chances of extension in this type of white cataract. It is very to do with the femtosecond. This is similar as the previous one. Thank you very much. Thank you.
Thank you, sir.
Yeah, Manbir, please proceed.
I'd like to ask others on the panel if anyone is also using femto-assisted cataract surgery, because most of us don't have access to this technology, and most studies have also shown that there is not any significant advantage of this as compared to conventional phaco surgery. So if others are also advocating this technology, what are the advantages and what are the cases where there is advantage of using this over conventional phaco surgery?
Yes, Dr. Anaga, you can proceed.
Yeah, so I've been using flax for the last 5 years. So what I have found is in cases where you have corneal guttata, that is fuchs dystrophy, where we know that already the cornea is a little weak and there is greater chances of risk of corneal decompensation, there I would definitely advise flax. In cases of subluxated cataract, having a perfect centered capsulotomy is a boon, and you can also center it on the lens capsule, instead of just pupillary this thing. So you have a perfect capsular axis, because that is so critical in case of subluxated cataract. In posterior polar cataract, it's very important because you have a good capsulotomy, and we can always use it to bail us out by using a 3-piece on the in the sulcus. In cases of patients where you have a very hard cataract, in mature cataracts, it really doesn't work so much, but I would always use a trypan blue to stain the capsule because it has a postage stamp perforation. So you may have skipped areas. So in these cases, it's very important to see that if there are any skipped areas, you need to use a Utrata and actually open it up. So in these are my indications, but yes, definitely. And in patients who need multifocals or multifocal torics, definitely you have a good 360 degrees covering on all the sides, which is so perfect. So definitely the visual outcomes are good because you don't have sometimes, once in a while you might have a rhexis which is too large and you have one end of the IOL coming out. You may have an IOL tilt or a slight decentration, which may affect visual outcomes in these very premium lenses.
Thank you, ma'am.
Yes, Dr.
Yes, I think a few other situations to add on is a flax is superior to or can be considered where you want a very well-centered rhexis and a rhexis which you do not want to go wrong, as you would want in your toric trifocals. Basically, when you're using your higher-end premium IOLs, and you want a good centration and you do not want anything to go on with your rhexis. That is one area where a flax definitely scores over a manual surgery. As we all know, the outcomes otherwise are pretty much comparable as subluxated lenses, as Dr. Anaga rightly pointed out. And in mature cataracts, hypermature cataracts, where you want to avoid an Argentinian flax sign, that is again another scenario where, and in these flax really does not work. It only helps you with your rhexis with good centration and repeatability. And you will have to do a manual phaco in most of these situations because the flax does not cut the lens in these scenarios here. So that's another scenario where you would want to. And if you're planning for minimal astigmatisms, then if flax allows you, your refractive suite allows you to do arcuate keratotomies here. So if you find your patient cannot afford, you do not want to go in for a toric. And if you're using a flax, then for T1, T2 torics, then you could probably plan to do your arcuate keratotomy incisions instead of using a toric. So that's another scenario where you can use the flax comes in useful. And again, in posterior polar cataracts, because it does give you a posterior cortical cushion here. And that's a scenario where you could again want to use flax over a manual technique.
Two places where flax would not work is one is a very small pupil.
Yes.
Obviously, and if you have a corneal scar, because the femto laser will not penetrate.
Penetrate.
So we should not advise in these two.
Yes.
So as Manbir was saying, we have enough data published now, and there are a lot of articles wherein what HUA was created when flax was started. There are studies now that flax give comparable results, and actually now there are studies also we say that flax investing so much money and flax is not really much helpful. So except for the few situations which you mentioned, the advantages of flax are comparable with the routine phacoemulsification procedure what we do. But we all know that every technology comes with a cost. So if you can afford the technology, I think we should not refrain ourselves from upgrading our technology. But of course, if you can't afford the technology, we are very good at our own skills. But yes, data does support now that flax is not superior to the routine phacoemulsification.
Excellent presentation, Dr. Pawan.
Thank you. Thank you.
Thank you, Dr. Pawan Sthapak.
Thank you.
One small thing, we should not forget the Zepto also. In cases of a mature cataract, probably I would prefer a Zepto to a flax where the patient cannot afford, because we know what is important is the capsulotomy there.
That's right.
That serves the purpose. So I have used Zepto in such conditions quite frequently.
So there's a new technology also is coming now, which does the Rexis in, I think, 8 seconds.
Capsule laser, yeah.
Capsule laser, yeah. So
Dr. Kakadia has come up with this, I think.
Yeah, so soon this also will be available in the market now.
Yeah.
There are comments or questions from the panel. It's time now to wind up. So on behalf of the AIOS headquarters, it is my pleasant duty to propose a vote of thanks. At the outset, a congenial thanks to our President, Dr. Harmansh Lal, for participating and giving his inputs for the first three talks. Then my congenial thanks to all the four speakers, Dr. O.P. Agarwal sir, Dr. Purendra Bhasin, Dr. Prerna Upadhyay, and Dr. Pawan Sthapak for their wonderful expositions. And last but not the least, to our expert panel, Dr. Vanati, Dr. Somashila, Dr. Pradeep Mohanto was there for some time, Dr. Amit, Dr. Vardhaman, then and Dr. Anaga. So sincere thanks to you all for participating in today's event. And I hope the delegates have got a wonderful exposure to the various nuances of cataract surgery. Thank you all. We may now